of Psychiatry and Behavioral Sciences at Stanford, and he's going to talk to us a bit about the effect of ketamine on OCD. Thank you.
And to the organizers, excited to come here. In preparing the talk, I realized coming to Oxford is kind of like coming to the mothership for anyone interested in the variations of psychopathology. We heard a bit about Robert Burton. I want to highlight this just because he has one of the very first descriptions in text of what we now might recognize as obsessive-compulsive disorder. So one of his variants on melancholy, of that he describes, another dares not go over a bridge, come near a pool, rock, steep hill, lie in a chamber where crossbeams are, for fear he be tempted to hang, drown, or precipitate himself to suicide. If he be in a silent auditory, as at a sermon, he's afraid he shall speak aloud unawares, something indecent or unfit to be said. So, yeah, I don't know Oxford very well. This is my first time here, but I did spend 5 very happy years in Cambridge, and in reading about this was excited to realize there was a contemporaneous subject matter expert in East Anglia, about 10 miles up from Cambridge, where the River Cam becomes the River Ouse. And this is John Moore, the Bishop of Ely, who actually wrote a whole paper, a sermon that he presented to the Queen, all about this struggle of his parishioners who had blasphemous thoughts or intrusive thoughts. So he writes, "These unhappy persons who have naughty and sometimes blasphemous thoughts start in their minds, despite all of their endeavors to stifle and suppress them. The more they struggle, the more they increase." And I think quite wisely he says, "These frightful thoughts do for the most part proceed from the disorder and indisposition of the body. I take them to be no more marks of the divine displeasure than sickness or losses, or any other calamity you may meet with in the world. Their case is not as dangerous as they take it to be." And I think there's something very moving and human about this person, representative of God, whose office looks like that, telling his parishioners, this isn't about God, you've got an illness, everybody gets sick. So, again, his conclusion, not so dangerous as they take it to be. However, I would argue in the 400 years between these two, the distance between these two buildings in time, and the time between Burton and Moore and now, OCD is still really a problem. Quite dangerous, in fact. It's common, it's morbid, it's insufficiently treated. So the prevalence of OCD is about 1.5 internationally, replicated in a number of epidemiologic studies. It's really impairing. So by definition, people spend more than an hour a day preoccupied with distressing behaviors or thoughts. They're often stuck in rigid, inflexible routines that really limit their ability to engage in work, life, school. It's complicated. Rates of comorbidity with depression, other forms of anxiety are high. Suicidality is surprisingly high in this population, and it can be complicated by insight impairment. So in some ways, loss of awareness or failure of awareness that the thoughts or behaviors one might have are a product of illness as opposed to rational. This gap statistic is bad for most disorders in psychiatry, but particularly bad for OCD. On average, it's 17 years between the onset of symptoms and when someone finally gets an accurate diagnosis and a trial of evidence-based treatment. That said, when they do have the trial of evidence-based treatment, those treatments are pretty suboptimal. So if you think about behavioral therapy, CBT with exposure and response prevention, in fact, pretty much what Bishop Moore recommended to his parishioners. This is hard to access, it's time-consuming, and like other kinds of exposure therapy for anxiety disorders, it's exactly what the person doesn't want to do. And very challenging, and there's a high rate of dropout. Medicines for OCD, so the gold standard is a serotonin uptake inhibitor, but really not very golden. People need higher doses. This is shown in good meta-analyses that higher doses have better response rates. It takes longer to respond with OCD to an SRI than it does, say, for depression, often months rather than weeks. And even with an adequate dose and trial, about 40 to 60% of people won't have an adequate response or won't respond to an SRI. So a real need for new treatments. So I'm going to tell you about the MCAT study, work looking at ketamine and OCD, and I just want to say this is the brainchild and the product of the initiative and leadership of my colleague and mentor, Carolyn Rodriguez, who I know wishes she could be here. Also a big team of co-investigators and a whole village of psychiatrists, postdocs, psychologists, research coordinators, and others who made the study possible. I'm going to talk a lot about conflict in this talk, but there are no financial conflicts relevant to disclose. So just in terms of goals, I'll just speak briefly as to why we would consider ketamine an OCD, and we can look at some data about effectiveness, or efficacy, I should say. We can talk a little bit about some preliminary work looking at potential predictive biomarkers, ways to identify patients who would benefit from this. And then focusing on the same biomarkers, we can think a little bit about mechanisms by which ketamine may be working. So just given the high rates of misdiagnosis of OCD, and being the only speaker talking about OCD, I hope it's all right just to focus a little bit on what it is. So OCD is characterized by the O, obsessions, and these are recurrent, intrusive worries, fears. They're unique to the individual, but they come in stereotyped types or clusters that can be identified. So very commonly, you can have what are called harm obsessions. So, for example, the fear that you can be responsible for a house fire, that you might have hit someone with your car, that you might make someone angry at work, for example. Taboo thoughts, we talked about religious, intrusive blasphemy thoughts, but often these are sexual or people have concern that they've had a sexual impulse that's somehow inappropriate or threatening to them. People may worry about contamination or illness. People may have preoccupation with certain numbers, superstitions, symmetry. And characteristic of OCD, something that separates it from other anxiety disorders, is that when you have the anxiety related to this recurrent intrusive obsession, there's an urge to do something. And that urge to do is the compulsion. These again come in stereotyped types, so arranging, checking, counting, washing. Almost always a person with OCD will have both obsessions and compulsions. I know there's often a focus on pure O OCD, but really those are compulsions that are internal, so things people are doing in their mind as opposed to in overt behavior. And they're almost always paired. So someone who worries about a house fire may repeatedly check the outlet or unplug and replug the outlet. Someone who worries about angering their boss may, in a kind of non-rational way, feel like they have to have all their work shirts arranged in just the right way so that they have the right feeling when they go into the office. And I can't emphasize enough how for some people these thoughts are really threatening and distressing. So sexual thoughts about children, so people who are concerned that they may be a pedophile, with no evidence to suggest that that's a reality for them. Highly associated with suicidality. I think the only patient I've had have to come back from the Golden Gate Bridge had this. Another patient, I remember, his hands were bloody from checking his zipper so many times every time he thought about a child or was near a child to make sure his pants were up. By definition, more than an hour a day, suffering obsessions and compulsions, distress and impairment. And then just to talk about assessment, so these are measures we'll look at. The Y-box here is the gold standard. This is the product of an expert interview. It's a cumbersome instrument. It takes about 40 minutes to do a good Y-box assessment, scoring obsessions and compulsions on average over the past week. Given that we're studying potentially rapid-acting treatment, we also use a visual analog scale, which essentially asks people, how bad are your obsessions on a 1 to 10 scale? How bad are your compulsions? And we put those together. Response criteria in OCD is typically between a 25 to 35% reduction in Y-box. Here we've defined it as a 35% reduction. So why consider ketamine in OCD? So I have to say, as a trainee and early attending, when I first heard about Carolyn's work, and I think as many cynics might say, we know ketamine's a rapid-acting treatment in depression. The history of psychopharm trials, let's try it in our disorder. But I think that's really overly cynical. First of all, there's a real need for rapid-acting treatment in OCD. As you remember, as I mentioned moments ago, the duration or the lag to response with SRIs is much higher for OCD than other conditions. So a real need for rapid treatments. And then over the 90s, early 2000s, there was really a confluence of data that suggested a glutamatergic basis for OCD psychopathology. And this comes from multiple studies showing hyperactivity in the striatal thalamocortical circuits that are thought to be glutamatergic primarily. Good translational models like the SAPAP3 model of overgrooming in mice, which is a postsynaptic glutamatergic synaptic protein. And then some very small clinical trials of glutamatergic drugs with some promising signals in OCD. And of course, all of us in the room know that NMDA and glutamate isn't the only potential action of ketamine. There was also, as Alan mentioned yesterday, this really striking study from 2005 from Larry Curran, who showed that a single dose of 4 milligrams of morphine given once in a week over a 2-week period, so 2 doses, led to response in a substantial proportion of really treatment-resistant individuals with OCD. So, at that time, the idea of a kind of pulse dose treatment that could provide lasting effects was really quite striking. So the other thing to say is that, on that basis, Carolyn did her original case report and sort of an early pilot trial of ketamine and OCD, and the results are really striking. So as you can see over the green infusion period, using the visual analog scale as a report of OCD symptoms, ketamine just turned off the obsessions and compulsions. So people had a really remarkable drop almost instantaneously with this medicine. So in my experience of, which has been a while now, but working with ketamine for depression, you'd often see the person come back from an infusion and say, I'm not sure if I'm feeling any better, and they would feel better the next day. But with ketamine and OCD, it was really quite immediate. So about 50% of people met responder criteria in this study, and this was durable through the week. In fact, this was planned as a crossover RCT. She wasn't able to analyze the crossover because of carryover. So the effects of ketamine were still going strong a week out from a single infusion. So just caveats, obviously it's a small N. This was a saline control, so ineffective blinding. And at the same time, an excellent group from Yale, Michael Bloch and Chris Pittenger and others, had done an inpatient trial of ketamine for people with severe depression who were on medication who also had OCD symptoms. And that trial was negative, so no one met response criteria for OCD. And to the degree to which their WIBOX improved, it was attributed to improvement in depression, which the individuals did experience. So concerned that maybe medicines might interfere with ketamine effects, or that what we were looking at is a change in depressive symptoms. So this leads to, just to reiterate, so a need for speed in OCD, a need for rapid-acting treatments, both glutamatergic and opioidergic, hypotheses about what might get OCD better, and then this really promising pilot data. So the MCAT study I'll tell you about was an NIH-funded trial in line with NIH priorities. It's a mechanistic trial with pre-post neuroimaging, EEG, cognitive testing, and then MRS during the infusion in a scanner. But in terms of the clinical trial, it was designed to be a larger cohort to address some of the limitations and concerns, to use an active placebo control. It was to be done in unmedicated patients and to exclude severe depression. So this is just the study flow. So 45 patients with OCD were randomized 2-to-1 to standard infusion of ketamine at 0.5 mg per kg over 40 minutes, or midazolam anxiolytic benzodiazepine control at 0.045 mg per kg over the same time period. Again, this was delivered in an MRI scanner. Inclusion criteria, so you had to have OCD at least moderate severity, near constant obsession, so that we could assess sort of change on a shorter time scale. Individuals had to not be on medication. This is for adults, and we excluded people with severe depression, psychosis, bipolar, or substance use disorders. So we screened 153 people, enrolled 45. On balance, there were more men in the study than women. Average age was 35. OCD severity was moderate to severe, so an average WIBOX of 26. Depression severity was low, so most people weren't significantly depressed. The Hamilton mean was 7. And people had had a considerable amount of treatment prior. So most had had a prior trial of a serotonin reuptake inhibitor, 20% had had augmentation with atypical dopamine blocking meds, and 38% had had CBT with exposure and response prevention, which is the gold standard behavioral treatment. So just to look at the initial results, so it replicates the pilot trial. So a dramatic drop in WIBOX score, now modified for a 1-day interval, from 26 on average to 14, compared to a 4-point drop in the midazolam control arm. This was significant at the 3 time points studied in the first week. And then also week 2 through week 3, still the ketamine receiving group separated from the midazolam placebo group. So if you just look by responder status, about 50% of people responded at day 1, week 1, and week 2. with some drop-off in responder status by week 3. Anecdotally, some people carried on for a few months feeling remarkably better. But certainly not all. At that point, the responder pool is down to less than a quarter. So I'll move through side effects quite quickly. I think as well tolerated as you can expect in a scanner, we had a few people with nausea, one who vomited, probably related to moving too quickly after the ketamine infusion. Dissociative symptoms were reported in both arms, although if you look at the intensity of those dissociative symptoms by the CADs, clearly ketamine had ketamine effects and midazolam didn't. I think in line with this, there was some degree of functional unblinding. 86% of people who got ketamine recognized they had ketamine. About 75% of people who got midazolam recognized they'd had the midazolam control, although confidence wasn't super high for those guesses. So is it effective? So 50% response rate at 1 week. Effects still separating from the midazolam control at 3 weeks. It was well tolerated. Of course, we're not at a point where we can say, treat your OCD patients with ketamine, but certainly promising and worth continuing to explore. So 50% of people got better, 50% of people didn't, and we shouldn't forget about that half, or sorry, I should say didn't meet response criteria, and they may have had some symptomatic improvement. But if we think a little bit about who might benefit from ketamine for OCD, we can start to think about some of the potential predictive biomarkers we obtained in the study. And I want to focus just on 2 here. One, so the computer is for a 30-minute computer-based battery of neurocognitive tests, which we did a day prior and a day after the infusions. And then they also had functional MRI a day prior and a day after the infusion. So just to focus on the neurocognitive assessments, I'm emphasizing this, I think, A, because they're cheap, they're easy for patients, and they're not used enough in drug studies. So, so many studies looking at neurocognitive correlates of different disease states, but I think it can be quite powerful when you look at them pre and post interventions, especially rapid-acting interventions like ketamine. So we used one developed in part by Lee Williams at Stanford. This is an assessment called Web Neuro. It takes about 30 minutes. It has a number of validated kind of typical neurocognitive tasks, looking at motor, memory, attention, cognitive control. And then individuals get a Z-score based on a normative cohort matched for age and gender and education. And I'm going to focus particularly on this sort of implementation of a Stroop color-word conflict task. So we call it a verbal interference task. You can see these 2 sets of stimuli. Participants have a minute to process a number of stimuli on the right, where they're asked to select the button below that corresponds to the written word, so red on the right. And then they also have a separate round of 60 seconds where they're asked to name the ink color, the font color of the word as seen on the left, so blue in this case. And then their normalized score for word reading is subtracted from their normalized performance for color naming to give a verbal interference score. So people who have a high verbal interference score, these are the Stroop super performers who can motor through identifying the ink color without being distracted by the written word, which is so often in conflict with the effort to name the ink color as per the Stroop effect. So I'm focusing on this in particular because this is what sort of came up most strongly as a baseline moderator of response to ketamine. And so this is the graph. I think if you remember anything from the talk, consider this. So on the bottom, this is looking at the verbal interference task score. So these people over on the right are sort of the Stroop super performers. These people on the left have a lot more interference and they struggle with this task. They're very slow to name the ink color relative to the written word. And as you can see, those people with a positive score, the sort of better at the ink naming relative to their word reading, had a strong separation between ketamine and midazolam, so strong response in terms of reduction in Y-box symptoms, where those who struggled with the Stroop task and had more interference didn't separate from midazolam. So the model here is a greater cognitive inhibition, which is often the way we interpret Stroop performance, predicts greater response to ketamine versus midazolam. So looking in the literature to see if this is identified or seen, we do see, we found a couple of papers. So one back from 2012, a study in Brazil looking at fluoxetine and CBT for OCD, which showed that higher Stroop performance on a paper and pencil version predicted better outcomes in this trial. And then just last year, a group in France published a correlative study looking at people with OCD's history of medication use and response, so kind of a score of treatment resistance, correlating that with neuropsychological variables, found that Stroop came out as, or poor performance on a Stroop was associated with poor response to prior treatment trials. So it may be that what we're seeing is specific to OCD rather than to ketamine. But we can consider that responsive patients to ketamine might have high cognitive inhibition or some altered response to stimulus incongruity. And I'm highlighting that because Rachel Marsh and Blair Simpson at Columbia had previously developed an imaging paradigm looking at stimulus incongruity and showing that individuals with OCD had altered responses to this. And so this was incorporated as a pre- and post-measure in the MCAT study. And I'm not a neuroimager here, but I'm going to share work from Shui Zhang, a wonderful postdoc working with Lee Williams. And this looks at something called the Simon task. And so the Simon task, sorry, I'm here somewhere. Well, I'll leave it out. You can see where there are arrows. So the participant in the scanner has to identify the direction of the arrow to choose either left or right pointing. And the arrow will be positioned on the screen either on the left or the right side. So you can I got it here. You can see that there might be an incongruent presentation where a left-pointing arrow is on the right side, or a congruent one where a right-pointing arrow is on the right side. So if you look at bold activation during the stimulus presentation, contrasting incongruent with congruent stimuli, Shui and Lee found activation in the putative cognitive control circuit, so activation in the dorsal anterior cingulate and in the bilateral anterior insula. So replicating in some ways the work of Rachel Marsh and others. So I highlight this because they saw that this level of activation in response to incongruency was correlated with responder status. So if they look at non-responders versus responders, you can see higher levels at all three of these regions of interest. You can see higher levels of activation in the responder group compared to the non-responder group, implying that sort of a higher level or a more active sort of cognitive control network, which we could imagine might correspond to higher levels of inhibition, was similarly associated with response to ketamine versus not. So for who, so far the take-home is that it's for patients who we might describe as having greater cognitive inhibition, less interference on the Stroop task, and greater bold activation to conflictual stimuli. So are these potentially mediators of treatment? Is ketamine working through these circuits to achieve a symptom response? So if we look at now an analogous figure to what I showed you before, but now, sorry, I'm losing this. On the x-axis, we're seeing change in Stroop from pre to post. You can see that people who, people who responded more strongly in terms of reduction in Y-box symptoms tended to get worse at the Stroop task. In other words, they became more aware of the interfering word, or at least that's one model we could suggest, that they had a more difficult time processing the conflictual stimuli and were slowed down in their word reading relative slowed down in color naming, relative to their word reading. So to think of this as a true mediator, you need to both show a relationship between the mediator variable and the outcome, as well as the intervention has to change the mediator variable. This is a little bit less clear. If you look at this on the left, you can see that performance after midazolam increased slightly, maybe related to midazolam. It may also be just a practice effect on the task, but that the average change was greater in midazolam compared to ketamine. So another way of thinking of this is that ketamine might be impairing cognitive control in some ways, or we could say reducing abnormally high cognitive control in responders. So one interpretation. So just going back to the Simon task, which I showed you, so in a parallel way, again, not entirely straightforward. Non-responders actually increase their level of bold activation in response to the conflictual stimuli. But if you look at responders, their bold activation to the conflict-laden stimuli seems to go down. So perhaps it's a normalization of this sort of cognitive control function, or if we're just thinking about the responders, as I think Alan was suggesting we do yesterday, our model might be that, again, a high level of cognitive control, or perhaps abnormally high, is reduced by ketamine. So by what mechanisms? So obviously we haven't said anything about opioid versus NMDA, but we might start to think about decreasing or normalizing behavioral or cognitive inhibition, evidenced by the fact that after ketamine, decrease in symptoms seems to correlate with an increase in Stroop interference, and that responders show decreases in bold activation to conflictual versus non-conflictual stimuli. Just a couple minutes left. This is where I'm going to get super speculative and say that as a clinical psychiatrist, I think in line with what David Mathai was saying earlier, I think we should be really interested in what's happening at a psychological level in response to interventions. And can we think about things like cognitive flexibility and insight as potentially impacted by ketamine in ways, for OCD, for example, that might perpetuate learning. So I think we often talk about cognitive flexibility. Certainly there are imaging paradigms and ways of thinking about it at a network level, but I think we don't often assess it in our participants or our patients in a clinical way. And I think these neurocognitive tests are one sort of way to see into that. Again, as a clinical psychiatrist, I'm very interested in insight, particular challenge in OCD. And there are actually a number of limited set of studies, but if you look at papers that correlate measures of insight with neurocognitive performance, again, the Stroop comes out in that higher performance on a Stroop, we've shown in hoarding disorder, is associated with poor awareness of the degree of clutter in someone's home, so an OCD-related disorder. A group in India has looked at a measure of insight in OCD and shows that correlates again with Stroop. This has also been shown in other illnesses, bipolar disorder, for example, the Canelo paper. So as we think about something like these neurocognitive measures or Stroop performance or cognitive inhibition, we can think about this as a predictive biomarker. We can think about this as a potential mechanism for ketamine. But I think we also have to keep in mind what it means in terms of psychopathology, in terms of the participant or the patient's experience. And so just given, I think, interest in this that we were speaking about yesterday, I added just a super preliminary slide. This is from another study that's ongoing now, just looking at about 15 people for whom we're using a different implementation of the Stroop task. And I told you about the sort of different measures we use, a visual analog scale and the Y-box. If you just look at the ratio of that, so in other words, we ask people, how bad's your OCD? And then we do an extensive interview to sort of qualify or quantify their OCD. And look at the ratio. You can identify people on this end who don't seem to have a lot of distress, but when we assess, we see a lot of OCD symptoms. Or on this end, who have a lot of distress, think their OCD is terrible, but when we assess, it doesn't seem to score as high as other cases. And if you look at awareness of symptoms in that way, you can see a correlation with performance on a Stroop task. So again, I think this kind of processing of conflict is something we should keep in mind as relevant to the subjective experience of our patients and related to variables like insight, which are poorly understood and relatively understudied, but I think relevant to how our patients do after these treatments. So very last thing is just to say a few other ongoing studies. We're looking at nitrous oxide as an analogous NMDA and opioid agent, anesthetic agent as a rapid treatment in OCD. We're looking at dextromethorphan as an NMDA antagonist, potentially opioidergic, boosted by fluoxetine, which is a primary treatment for OCD. And we have the MCAT2 study, which will address the opioid question. So open label infusions of ketamine, for which people will receive a blinded naltrexone versus placebo pre-med. And so this, I think Alan mentioned yesterday, is investigator along with Boris Heifetz and again, PI Carolyn Rodriguez. So hopefully more to share in a couple of years. And thank you very, very much for your attention.
Thank you very much, Peter. We may have time for one question. Esther, please.
Yes, thank you very much for this great talk. Yeah. How do you explain the reduction in the response rate from week 3?
Why do people lose their benefit at week 3? I don't have an explanation. I think right now we're doing sort of descriptive studies of what this does. I mean, I think, I'm talking about, potential psychological mechanisms. Of course, we need to think about what's going on at a kind of, synaptic level or biological level, and I don't know to what extent, those different levels of explanation may speak to when symptoms are lost or not. I think, again, this speaks to, I think the caution we need to have in sort of rushing to start doing ketamine for all of our patients with OCD, right? This is a single infusion. We're looking at a prolonged response. We don't know what repeated infusions would do. We don't know if people would tolerate the effects or how long people can stay better with this approach.
Thank you very much, Peter.